If you have a question, please come up to the microphone so everybody can hear the question. Just leave it on the diesel.
Okay. After. I have a question for Dr. O'Malley. You talked about letting the flowable composite rest for 5 minutes before we build so we avoid stress. You have any advice regarding the time that we light cure our composite? Like we have a Velo lamp, we can put a very quick mode. Does it make any difference for the tension in the tooth?
Hello? Oh, so after the 5-minute wait, so that the half millimeter, 1 millimeter flowable at the pulpal or the dentin floor has polymerized, you're talking about those next increments?
Well, even the first layer, is it better to have a lamp that will cure it slower, or it doesn't make any difference having a quicker mode?
I don't know of any studies that shows one way or the other, but as you're building the bulk increments, and there's some studies showing the pulse or slow cure seems to decrease the stress on the shrinkage and on the bond itself. So
you would advise not using those very quick modes if possible?
Yeah, you don't want to put it on the ultra high and blast it on the thing because you're just going to shrink the thing faster and create more stress that way. So you'll see. So when you lay down a small layer and then you cure it, and then you go to the other side of the tooth and you lay down a little bit and you cure it, you can cure it. Let's say you're using a traditional curing light that's 20 seconds, right? You could cure it for 4 or 5 seconds in one area, 4 or 5 seconds in the other area, and you're going back and forth, and over time you're curing at that full amount. Main thing is you just don't want to make sure you're getting much more than about 1 millimeter or so before you have a full cure on those areas. So you don't want to stack higher where the light can't get to it.
Thank you.
Welcome.
No. We're kidding.
So actually, this is a serious question for Griff. What do you think the motivation is? Because you went through all of this about how ADA and the various organizations are really trying to resist this change that's obviously coming. But what do you think their motivation is for trying to hang on to, other than just not wanting to change? Yeah, I mean, do you think that there is some financial, some background?
I can only speak to what I know in my town in Austin, because I did wonder that too. Is there money changing hands here? And I know in Austin in 2011 when we were fighting a battle then, that year the CDC gave Austin $9 million to do a smoking cessation survey. We're a smoke-free city. You don't bite the hand that feeds you. So I know from a local standpoint, big cities get a lot of money from the CDC. That I know. ADA, we've all heard the rumors that they own 2 patents on mercury, and that's why that's still around. Fluoridation, I don't know, because, and I don't think even Dave Kennedy knows, because we've talked about this. I just think when you're wrong for so long, it's really hard to finally say, I'm sorry.
Right.
I really do. I think it's just that. I think it's that simple. You have a follow-up on that or something, Mike?
So this relates to my work at the university, and we work pretty closely with the people who do the fluoride research. And the thing that struck me, because I had wondered about this for a long time, is that each year, and I don't know, this is probably different from state to state, but each year people from the dental school and from the Indiana Dental Association have to go up before the state legislature, one of their committees, and say, what is the state of dental health in Indiana? And then they're typically having to defend the problem of access to care. And so the way this conversation typically goes is, yes, we know that there's a problem here with access to care, and we're doing the best we can with donated dental services and so forth, but we got everybody covered because we're fluoridating the water. And I think that's the thing that they're hanging on to because of the access to care problem.
I'm sure you're right, but as I showed you with the study from 2009 in JADA, high amounts of fluorosis,
I know,
high amounts of decay.
But that mythology still exists in the minds of the legislators.
That's exactly right.
Yeah.
And I can tell you, in the battle in San Antonio, my hometown in 2000, I went down there. I was set up for debates. The opponents never showed up. They still let me do my spiel. I thought I did really well. I had other doctors involved. And at the very end, it took a Hispanic, respected dentist to speak Spanish on the radio and say, our kids are going to get hurt here if we don't do this. And that was it.
Yeah, I think that's the only way, because the legislators are going to have to realize that their constituency is getting hurt.
And two scientists, and they get up and they argue, and I'm no scientist, but I know a little bit about fluoride. You get up and argue, there's no winner. It doesn't matter. My last debate, I actually said, they're going to say this. They're going to say it's one of the top 10. They're going to say this. I literally said that. The next person gets up and they go, it's one of the top 10. And I look around the audience like, I just told you that. And nobody laughed. No one thought that was funny. I literally said what they were going to say. Doesn't matter.
I live in New York, and I'm having a lot of difficulty with getting DNA testing bacteria and things like that. Any suggestions besides sending my patients to New Jersey? Is there anything coming up, or Connecticut, or Rhode Island, or some other state? And then I can't treat them with any IV. When we do our surgeries, we can't treat them with vitamin C or glutathione, the mixtures, the cocktails that are needed for those patients after the lab work has been done. So I'm sort of stuck. Should I move?
The quick answer is yes.
Just that button on the side, slide to
Yeah, the easy answer is yes. New Jersey is a nice place. The reality is that because all of the health insurance companies are located in New York, they really have a draconian grip on the state medical board, and they won't allow anything to take place there. The doctor's data can't do anything. So all of my patients in New York, we have to get creative. I need to send the material out, and then it gets sent in, and then it can't be shipped out of New York. All right, if you send something to doctor's data and there's a return address of New York, they'll destroy it. So you have to get creative.
Dr. Bergeson, first of all, your lecture this morning was very enlightening, I'm sure. Did anyone see his lecture this morning? Yeah. Okay. And I don't know where to start this, but I had informed you that your scientifically, medically defensible position has been in the medical and dental literature from 1880 to 1940. Everything he said this morning is published. He didn't know it, and nobody in dentistry or medicine knows it. I've uncovered this as part of an anthropology project that I'm working on. That said, when did you, because you're a legend in Chicago, you were at Northwestern in the orthodontic department, and and I heard about you when I was in dental school in the early 80s at Loyola. When did you come about understanding the importance of recognition of antecedents to airway disease based on a child's face and jaws? Like, was that part of...
1870.
Yeah, right. No, but that wasn't part of your teaching at Northwestern. Or...
No, it wasn't. I didn't know about it at then. But I don't know if I told this story or not. You know, when you get older, you forget what you said 10 minutes ago. But anyway, I had a mother that called the office one day, and it wasn't my patient, it was somebody else's patient, and the child, they would take her to the movie theater, and she would snore so loud they could never finish the movie. And when she started wearing one of my appliances, she didn't snore anymore, and she said they could finish the movie. I had a feeling that was probably maybe 16 years ago, something like that. I can't remember, but I wasn't certainly the, you know, Guillemot is the one that really started it all, and he was an amazing person. He just recently died, but he's the one that should really take credit. He's the father of sleep issues, other than those people that you mentioned that were so earlier. But anyway, I never taught it at Northwestern, but I retired from there quite a while ago. I'm 130 years old, you know.
You look good.
What are you drinking?
Very good talk on biomimetic dentistry. Thank you, Dr. O'Malley. Is there a particular book that you might want to mention, or several books? You know, I know you mentioned various leaders and literature, so anything like that. Just not a huge textbook, but just, you know, more of a popular introduction to it. Maybe even something the patient might read, an interested patient.
There is a article by Dave Alleman and Davey Alleman Jr., both dentists. Dave Alleman, one of the pioneers in biomimetic dentistry. It's called The Protocols of Biomimetic Dentistry. I forget what the publication is from. If you go down to the booth, though, you can see where that article's coming from. We also have it up on the website, the Academy of Biomimetic Dentistry. That's a really great little cheat sheet, because, it's a great cheat sheet to help a person understand some of the very basics in biomimetic dentistry. And the reason that I wanted Saul here, and Yuko introduced him here too, was as a member of the IAOMT, I felt like it was the perfect evolution for all the IAOMT practitioners. But anyway, that's a great one, and to some of my colleagues, sometimes I'll send that out to them. If you remind Becky, somehow we can get it onto the synopsis or whatever is being recorded and sent out. We'll be happy to do that.
Dr. Bergerson, I was wondering if you would address briefly your use of hand films and using skeletal age as opposed to chronologic age in the timing of your treatment in your orthodontic career.
Your question, I think, is at what age, skeletally, or?
Well, how you use hand films.
Oh, the hand film.
How you use the hand films to...
well, the hand film can be used to predict spurts after about 6 years of age. So we can predict the pubertal spurt within 2 or 3 months accurately. However, that's only good for standard orthodontic treatment around that age, so you can time treatment according to that. When we get to the younger patient, I'm usually timing treatment according to tooth eruption, and it seems to be that's more important than the skeletal age of the child. And younger children always have a lot of growth. So if we started orthodontic treatment when the first permanent incisors start erupting, that's the time. That's more important than the skeletal age or the hand film of the child. So I don't know if that answers the question.
But I think also
Yeah.
what the
I'll give it to you.
I would say I think what kind of discrepancy there can be between chronological age and skeletal age that you found.
Probably the greatest one was about 4 years difference. So a child that would normally mature, say a girl at 13 and a half, I've had one maybe 9 and a half or 9 years of age in my office. However, the record, I think, was in a South American country where the mother was pregnant at 4 or 5 years of age, and her daughter also was pregnant at about 4 or 5 years of age. There usually is about 1 out of 1,000,000 people that might have a skeletal age to chronological age difference like that. So it's quite rare. I don't know if they'd even have one in Boston here, but I've never seen one that mature at that early age. But you do have to watch females because they will mature, a couple years earlier than boys, and their appearance might be that you might think they're very mature when they're not mature. Sometimes they don't look very mature and they are mature. But I might mention, I know you want to answer, I might mention one thing. I had a patient one time that we were treating orthodontically and nothing was happening. I always had a recurrent nightmare that we would extract bicuspids and I couldn't get the canines back and we'd end up having to have 4 bridges put in. So I had a patient one time that the canines absolutely wouldn't move. And I asked the mother, is there anything in your child that I should know about? And she said, well, my daughter hasn't menstruated for several months and we're very concerned about it. I said, if that ever changes, would you let me know? One day, all of a sudden, the canines started to move. She came in the next appointment. She said, oh, by the way, my daughter started menstruating last month. So, you have no idea what effects the hormones in the body have. They're unbelievable.
Okay, and just as a follow-up, because I've heard you speak so many times, but at what age are you comfortable with a child predicting their adult height? Because you can predict from the hand film, based on skeletal age and their present height, what their adult height is going to be. At what's the earliest age you feel comfortable predicting that?
He's saying, at what age can you use the hand film to predict the adult height?
You can use it at 7 years of age, and you'll be pretty accurate. I was about a ½ inch accurate over the years, I think, on the children. And so that you can do very easily.
I'm having a lot of young adults coming in because my age group, their kids are now like starting to go to college. But I've been finding 13 and 14-year-olds and 15-year-olds where their wisdom teeth are coming in. And I'm getting some contradiction on should we take them out early because of the changes, or should we wait, and then the inferior alveolar nerve and paresthesia. And we're finding with all of the changes in the hormones and with the food products and that are in our foods and in the environment, that the kids are maturing much quicker. How can you comment on that? Mostly surgically I'm concerned with, because I don't care that they're growing up quicker, but I do care about the hormones.
She's saying hormones and food, kids are
Maturing
much
faster.
faster, younger age, and then getting wisdom teeth at 13, 15. Should they take them out or wait until?
I can answer them.
Okay, we understand. Do you want to answer it? Or do you want
Yeah, I can. Children seem to be maturing earlier, and I don't know what causes that. It might be hormones in the milk. I have no idea. But there are changes in height that have occurred since the First World War. There are several inches of increased height in the American conscripts in the military. So there are changes that occur, and I'm not sure what that is. It may be our nutrition. I have no idea. Maybe somebody else has a comment on it.
Well, I mean, I don't know. I have 26 years of experience, so that gives me some. I would say no. We treat the wisdom teeth as foreign objects because oftentimes they act like it. But as a lot of us who see cavitations and stuff would tell you, had they just let the teeth come in and do their thing, and assuming they come in straight, probably wouldn't have these issues.
But if they're not, I'm not just...
So they're not coming in. So they're up in the bone, they're doing no harm. Why would you go after them?
I wouldn't go after the ones that are doing no harm. I'm only talking about the ones that are going to cause harm, that are somewhat interfering, let's say, 17 to 18, with the angulation and not coming up.
So are they, okay, so we've seen lots of wisdom teeth that are laying completely sideways in 60-year-old people.
Right, and do you leave them alone?
Leave them alone.
It's the ones that are causing the problem.
Then you have to deal with it.
But you deal with them earlier, but then you don't, because why? You don't know how they're going to grow.
For me, I don't deal with them until they're causing a problem.
Yeah, you just answered my question.
Okay.
Me personally, I still think that it's most appropriate to address them when you have 1/2 to 2/3 root formation. Okay, and that's again assuming that it's one that you deem as problematic. Again, obviously, if they're full bony impaction and they're floating down in the inferior border, and okay, we're not going to go after those. But to answer your question, if you feel the tooth warrants removal, root formation of 1/2 to 2/3 is appropriate, in my opinion.
Are you going? Okay. Yes. Question for Dr. Yurkovsky. Interesting lecture. Thank you. So you presented some of the interesting cases, almost like seems like magic. What is the short version of explaining the physiological mechanism of metal toxicity, like detoxification, so quickly? Because naturopathy is so complex. What is the quick version of explaining the physiological mechanism of actually getting the metals out of your body?
If I understood you correctly, the answer is in specificity. This treatment is highly specific. Number one is the key organ pathology in any chronic disease will always rest with a particular corresponding organ where pathology originates from. Now, let's say Crohn's disease, colon, right? Alzheimer or brain tumor, brain. Coronary artery disease, coronary artery. Diabetes, pancreas. So here we can make a specific and very specific and high meaning communication with that organ. It can be only established through homeopathic or homeopathic-like remedies application. That is, brain goes to the brain, pancreas to pancreas, ovary to ovary, and etc. And take another 1,000 tissues or organs in the body, zones or subzones, systems or subsystems. You always have that specificity that only homeopathy can provide, because pharmaceutical agents cannot make pharmaceutical brain. There is nothing that specific in herbs for the brain. For example, herbs can improve a little circulation to the brain, for example. Acupuncture can improve also perhaps circulation to the brain or energy supplies to the brain, nerves. But there is nothing that's specific in any of the interventions other than homeopathic, because it's made out of the brain. It's made out of the ovaries. You follow me? I don't know if you guys familiar, ladies, with homeopathic process, but what you do is you take brain tissue, ovary tissue, whatever tissue, coronary artery tissue, and through homeopathic process, you convert it from chemical substance into energetic substance. So it can energetically connect with the brain and say, hey, brain, release whatever toxins you have. It is not as simple as I'm saying, but I'm just saying, emphasizing point of specificity, okay? Because for certain substances like heavy metals, mercury, and toxic metals, you can use brain remedies as a specific communicator, as a specific email. But for things like other organs, other causes of illness, such as, for example, drugs, pesticides, organic chemicals, residues of pharmaceutical agents, head trauma. You cannot just say, hey, brain, go fix yourself. Do it yourself type of job. So there's a lot of variations to it. But that at least answers one question. So brain connects with the brain whenever we need to address a specific toxin that the brain would respond to when given the message from the brain homeopathic to expel it. Number one. Number two, we can also match a specific disease-producing agent or cause that is stuck in the brain, let's say Lyme disease, Lyme infection, viral infection, arsenic, lead, mercury, silver amalgam that is stuck in the brain. We can also match it with a specific homeopathic remedy that is made out of silver amalgam, mercury, Lyme bacteria, specific viral infection, etc.
How do you determine which organ you want to impact or work with?
Through bioresonance testing.
Okay.
When we test, we kind of map the body and see all the organs, main organs. It's basically we're asking the body like a lie detector test. Basically, we're asking the body, hey, show us all the red lights right now that are preventing you from functioning normally at this point, having good health. And the body says it's pancreas, it's a liver, it's a brain, it's a kidney, it's ovaries, etc.
So if you have
and from that, we find out what causes their malfunction.
So you have a patient that tests show high arsenic toxicity. No symptoms, obvious symptoms yet. How would you determine, through the tests you just mentioned, the resonance, which organ you're going to...
What about symptoms?
No symptoms yet.
No symptoms?
Yes, but arsenic was off the roof.
Well, first of all, people with no symptoms don't exist. You just need to know how to collect it. All right? Healthy people don't exist. You take whoever you take, from a child to professional athlete. You just need to know how to elicit this information.
Symptoms, you're right. No obvious.
However, you're making good point that it's not so much symptoms, the disease doesn't exist yet. Yeah. However, if I, for example, test someone's pancreas, find mercury there, they may not have diabetes yet, but if we leave that bullet there, that I call mercury or some other bullet, long enough, it's going to continue its distraction course for long enough and may create diabetes or pancreatic cancer.
So with your patients, when the symptoms disappear...
So we use bioresonance testing, answer your question.
With your patients, when symptoms disappear, do you retest them to determine that it's clear out of mercury or other toxins?
Yeah, through bioresonance testing, we can determine whether certain organs are free of mercury or not.
Okay.
Yes.
Thank you.
Over the course of my career as a part-time academic in pediatric dentistry. Yeah, this is directed at you. I'm looking right at you. I deal a lot with otolaryngologists, and something that seldom comes up, if ever, is a parent asking the ENT, why are my kids' tonsils and adenoids so big? And likewise, it's like they just want them out, right? Well, I see an analogy to wisdom teeth and oral surgeons is that you probably don't get queried a lot as to why are my kids' wisdom teeth impacted? Because it's so ubiquitous. But if I hypothetically were to come to you with my child and said to you, like, why do my kids' wisdom teeth, why don't they fit? Why are they like this? What did you learn in your training, or what afterwards? What would you say to somebody, or have you ever been asked that by patients who, they just want them out? But I'm just curious.
I don't have a definitive answer to that question. I've heard some theories. The belief that wisdom teeth are teratomas, and that for some odd reason we're just born with these teratomas, and usually there are 4 of them, and we need to remove them because they could be to your detriment, causing crowding and hygienic issues. I've heard one theory about the evolution of the human skull and how the human skull is getting smaller, and as a result of that, we're seeing more and more impactions and creating those issues that we undoubtedly all know they can create. I don't have a definitive reason as to why, if I'm getting the question properly, why wisdom teeth are impacted the way they are. You know, why do some people have 4 wisdom teeth fully erupted, no issues? Why are some people born with no wisdom teeth? Why do some people have 8? You know, there's so much variation here with the presentation of wisdom teeth. I don't, unfortunately, have a definitive reason as to why we have these findings. So, I mean, I hate to sound like the ENTers there, but yeah, I'm sorry, I really don't have a definitive answer as to why we see such presentations and why we're still dealing with these issues today. Oh, awesome. Cool.
So, I mean, it's not my research, it's Dr. Weston Price, but the evolutionary change, you can see it in first generation introduction. Are you familiar with his research? Let me preface it with that. Okay, so within one generation, the introduction of the Western diet, not only the chemical composition of the food itself, which will develop or will affect growth and development of the mandible and the maxilla, but then the consistency of the food. So raw, hard veggies, tough meats to grind, the way it helps develop the bone and the muscles and all of that and it's anti-inflammatory on top of that, so you're getting proper placement of the tongue and everything's in balance with the nose, so you're getting nice wide jaws and there is room for those third molars to come in. When you introduce that Western diet, sugar, GMOs, processed foods, soft foods, not only the people sick, so they're inflamed, they're breathing through their mouth, they're getting imbalanced, malfunctional components in their mouth with their tongue and their cheeks and their masseters and their airway. But then on top of it, it's soft, soluble foods. Infants, I mean, Dr. Bergerson could talk about this much more intelligently than I can, but the introduction of pacifiers, nipples on bottles, changing the morphology from the infant stage all the way through to when they're growing and developing as young children. Infants have those like soft crackers to prevent a choking hazard, but at the same time, they're not chewing on crispy carrots. So they're not getting that kind of blood flow into their mandible and the maxilla to get that nice arch that we're looking for. They're not having those really nutrient-dense foods that you need for bone development and growth spurts and all those kinds of things. So that's where we saw very quickly the mandible and the maxilla become very malformed, major crowding, major malocclusion issues, and the wisdom teeth are kind of the first to not have room for.
So, Dr.
Speaking of nutrition, we could just go to happy hour now.
Actually, I have a question. Dr. Beth, I have a question for you. In your slide about the different appliances that you used, the bottom one was for 13 plus in adults. How successful is it in that group, especially in adults?
One thing I love about Healthy Start is that there's a major mentorship program. So we try to coach doctors so that we keep them out of trouble. So specific to adults, that's when we have no growth and development to leverage. So we have much less ability to correct for crowding and correcting for overjet, overbite, those kinds of things. And then on top of it, if you saw the slide about eruption, once all of those teeth are in occlusion and the apices are formed and they have the PDL fibers in the roots, even if we can move it the millimeter, 2 millimeters, or rotate it 30 degrees, those fibers are going to work to kind of relapse the teeth. So we have to use retention, and that's something that we just build into the pre-op consult and educating the patient that's saying we can still have a really good result. We can correct your overjet and overbite by 2 millimeters at this age, but you're going to have to retain this either by wearing this appliance maybe once a week at night or once every other day, depending on how the patient responds to the therapy, or they maybe want to have a different type of retainer. But that's where we kind of see where we just have to be more selective in case management, because when they don't have that growth, that's when we need those more unnatural forces of the wires and the brackets, and we're pushing and we're pulling. My dad he's been treating patients for longer than me, and I would describe him more of a cowboy, and that he would get out there and he'd say, you know what, we're going to use a Schwartz appliance, and we're going to expand in an adult, we're going to create that room, and we're going to drive that force. And he's had wonderful case success. So I think we advise being more conservative. You can definitely have success with adults, certainly with habit correction. Getting that aesthetic, ideal, optimal, orthodontic outcome we're more conservative on. But then you'll meet some cowboys who are like, no, you just got to get in there and do it, because the doc down the street is going to mutilate this 13-year-old, so just get after it. So did that answer your question, I hope? Cool.
I have a question about a PRF, and when is it recommended to draw blood to prepare for PRF? Before anesthetic is injected or after, and why?
What we're seeing actually in what's known as first pass, as soon as you take a drug, especially a drug that's injected, the liver reacts almost immediately. Yeah, I'm not doing this well. You want to pull the blood before you do the anesthesia, the general anesthesia, because as soon as you inject anything into the body, we've already established nutritionally that if we're looking at vitamin D, it has to come out of the first vial that we're pulling. If we pull it out of the second or third vial, it's not there. The first pass says that the liver is reacted almost immediately, and most of the oral drugs have to be increased because it goes through the liver, and the liver already in the first pass is metabolizing these pharmaceuticals. So they have to give you more for it to get into a real dose. So we're seeing the same thing with PRP. I suggest you pull the blood, and then once you've pulled the blood, then go ahead and anesthetize, and go ahead and prepare your LPRF. All right. Yeah, oh yeah, absolutely, yeah.
Hi. Actually, my question is for you as well. I started with holistic dentistry a couple years ago, and I don't know enough about cavitations. And what I keep finding is that there's different ways of finding them or diagnosing them. What do you do?
Well, I'm almost the wrong person to ask in this environment. With traditional Chinese medicine being able to evaluate the organs from the pulses, I'm really finding it through my blood work protocol. But once it's there, you need to, it becomes almost a pseudoscience. You have to really feel sorry for my dental colleagues, because when I used to send them patients and I would tell them, you're going to have caries in these teeth, and you're going to have gingivitis, and you're going to have they wanted to know if I had a chair in my clinic, and I did not. I was just pulling all of these from the blood work. It's something that can be taught. That's why I wanted to present today, and it's really my imagining. It's my it's my desire to see you dental physicians become actually the primary physician for people. Any educated individual out there is going to realize that their dentist, well-trained, is going to pick up and be able to provide true preventative medicine before any MD does.
Okay, so this isn't directed at anyone in particular, but I'd love to know your opinions on this. I'm new to IAOMT. I joined in April, and I'm fascinated and so passionate about everything that I've learned from everyone here. The mercury exposure, the fluoride exposure, and I love being able to educate patients on how we're helping them, how we're helping our team members, and how we're helping our environment. The one thing, and Dr. McMillan and I were talking about this yesterday, the one thing that I am stuck on is our plastic use as providers and impact of kind of day-to-day contact, but then what we're doing to our environment with the constant plastic use. So can anyone comment on what they're doing for that or what we can do?
Are you referring mostly to BPA or just plastic?
But then also just what we're doing in the environment of just having lots of single-use only. Oh, I'm sorry. The BPA, the BPP, all of those kind of issues with the plastic, but then the long-term effects of even if it's an optimized plastic, the single-use only that we're just amassing in our oceans and in our water and all those kinds of things that are problems for our environment.
That's a great question. I can address the BPA issue because, as you guys know, our academy did a small study on that in Austin. There was a big company at the time that was testing that. And I sent them 5 different composites, the most popular ones, and said, will you test this for BPA output? Because people were concerned about that. And the guy called me back after 2 days and goes, why am I doing this? I go, because he goes, seriously, these numbers are a joke. He said, we can't even get, it's less than 1%. It was so low. He said, the plastic water bottle that you guys are drinking out of is equivalent 100% to a cancerous breast tumor. He goes, but the stuff you're giving me, we can barely even get a reading on it. So I thought that put our mind at ease with the BPA issue. And now there's Voco and other products and Diamond that don't have any. So from that issue, I think we're good.
Right. I'm talking about.
I know from your other issue, yeah. So we're harming the environment is the answer to that.
Okay.
Bottom line, right? We are. Go back to the old metal large, right? So the large sections used to be metal, right? Rich and those guys, little.
So Dr. Rosolini, you should address the perspective that you had yesterday, and I'm drawing a blank right this second, on the plastics. And the, I got it now. Kind of the discrepancy in our beliefs about protecting the environment from mercury, but yet we're putting all this plastic into the environment.
I mean, for sure. That's why I asked the question. I'm grateful. And I know my dad uses some metal suction tips and that kind of stuff so we can sterilize, but I still feel like there's more that I need to be doing. And after being exposed to this organization, I know that if anyone's going to figure it out, it's going to be the people in this room. If they're not even worried about mercury, they're certainly not going to start figuring out plastic. So I kind of brought it up, the question, to just say it's synergistic with everything else we're doing. Who's running point person on this? Because I'm really concerned and cool. I'm glad I just nominated us to go and try to figure it out. But it's a huge concern. Yeah, no problem. Yeah, perfect.
All right, you're done.
Our time is up. I want to thank all the attendees for their great questions and for our speakers for a wonderful day of lectures. Thank you very much.